Fortis Escort, Escort Hospital, Faridabad, Department of Pain and Palliative Care. Our topic is use of injectable orthobiologicals for knee osteoarthritis, a European ESSKA ORBIT consensus. Part 1, blood-derived products, platelet-rich plasma. Next will introduce.
Yes, Dr. Sai can start. Dr. Sai, can you share your screen? Dr. Sai is actually
yes,
and I'm so glad that she agreed. Even she's on vacation, she's traveling, but she'll still agree to present.
Yes, ma'am. Good evening, everyone. Today I'll be talking about.
Can you broaden it? Can you? I don't know how in the iPad. Dr. Deep, can she enlarge the screen, or how can she make it?
मैम थोड़ा इसको टच पैड को जस्ट यू कैन जूम इट, जूम हो जाता है टच पैड.
Yeah. Ab it's on the whole slide now.
It's on the whole slide. Okay. All right. You can start. Yes. Okay. You can start.
Good evening.
I'll request everyone to mute themselves other than the speaker. Thank you.
Good evening. Today I'll be talking about the use of injectable orthobiologics for knee osteoarthritis, a European ESSKA ORBIT consensus part 1. This is for blood-derived products, mainly platelet-rich plasma. As we know, osteoarthritis affects 500 million people worldwide and has a very high cost per patient, and knee is the most affected joint. So the treatment of advanced OA, as we know, is knee replacement. But for early stages, we have only symptomatic management with painkillers and some very small role of disease-modifying agents. Hence, orthobiologics here play a major role to bridge the gap. As we can see here, and we know that platelet-rich plasma is prepared by the following method. The patient's blood is drawn and spun in a centrifuge and components are separated. PRP is then injected via a syringe through image guidance into the treatment area. In this infographic, we can see that platelet-rich plasma RCTs done up to 2025. And as we can see in knee OA, there have been a number of trials with comparing them to all the other agents. The ones in green are the ones in which PRP is superior. Blue ones are the ones which are inconclusive, and red ones are the ones in which PRP was not found superior. Okay, then why do we need these guidelines? Just a second. Then why do we need these guidelines? Because there's a lack of uniform consensus, lack of unanimous opinions, and non-uniform administration protocols. We need some guidelines for this. Now, the role of platelet-rich plasma, it's the most commonly used orthobiologic, as we know, and it has some disease-modifying properties by delaying cartilage damage progression. Also, it reduces synovial inflammation, and these can be seen as changes in biomarker levels of pro-inflammatory cytokines. In this table, you can see that there is a plethora of growth factors released by the dense granules of the platelets, and they have various roles in tissue healing and repair. In this methodology, out of 48 RCTs on the use of PRP in knee OA, 38 of them found that PRP was superior versus all the other options. Now, coming to terminology, blood-related products. A wide variety of products that are obtained by processing peripheral blood with different systems or techniques, resulting in blood fractions enriched in therapeutic molecules. Though platelet-rich plasma is the most commonly used blood-related product, we do have others like platelet-rich fibrin, and nowadays injectable platelet-rich fibrin, platelet-rich growth factors, autologous conditioned plasma and serum, autologous protein solution, and alpha-2 macroglobulin. For the purpose of this consensus, PRP refers to any autologous blood product based on platelet concentration prepared by minimal manipulation techniques and does not include other non-platelet products like ACS or A2M. So the consensus methodology was adapted from the normal Delphi consensus methodology, and they called it the ESSKA formal consensus process. In this, 3 groups of orthopedic practitioners were included, and they were divided into a literature group, rating group, and the peer review group. Then they made questions and prioritized them according to clinical significance, answerability, and scientific importance. Then they divided these questions according to PRP rationale and indications, preparation, and PRP protocol for administration. Out of 275 citations corresponding to 217 manuscripts, this consensus was prepared, and all the work was done in 2017. So levels of evidence are as per standard, and they modified it a little. For grade A, at least 3 level 1 papers were present. For grade B, at least 3 level 2 papers were present. For grade C, cohort studies or comparative studies with good results, or high-level studies with non-conclusive results. And for grade D, since the literature is very poor or absent, only expert opinion was taken. Agreement scale, in this, the specificity of a consensus in which the raters agree to a common agreement, graded from 1 to 9 on a Likert scale. First, the first draft was prepared, then the ratings happened, then suggestions were taken, second rating round, then the second draft, then peer review, and then final document. So coming to the first set of questions, that is PRP rationale and indications. Does current clinical evidence support the use of PRP for knee OA? So this is a thumping grade A, and there is enough preclinical and clinical evidence to support the use of PRP in knee OA. As you can see, there are a variety of papers on this. Now, for which degrees of knee OA is PRP indicated? So this is also a thumping grade A evidence for PRP in mild to moderate degrees of knee OA. Here also we have a lot of papers. However, the billion-dollar question is about PRP and its use in advanced knee OA, that is KL4. Here the consensus concluded that PRP could be considered if the patient is unfit for surgery or declined surgery, has multiple comorbidities, low degree of expectations, cautious, and we have to have a cautious discussion on the result. But the evidence on this is limited. So now let us see the papers related to this. The ESSKA had another consensus for appropriateness of PRP in different clinical scenarios. And for KNL grade 4 OA, they said that PRP is not considered appropriate, and this is level 1 evidence. However, if our patient refuses arthroplasty or is unfit for surgery or has multiple comorbidities, then what can we do? So for this, another study studied PRP in different stages of knee OA, and they found that in all the groups, there is a decrease in VAS score and better functionality. However, this decrease was better in early as compared to late osteoarthritis, but there was a definite decrease. Then what are the other options if not PRP? So we know that corticosteroid injection is used. So now we look at another study comparing PRP with corticosteroid, and they found that intra-articular injection of PRP has similar results to one shot of corticosteroid. So as we know the deleterious effects of corticosteroid on the cartilage and the knee as a whole, we can go in for PRP in grade 4 OA in specific conditions. Coming to patellofemoral OA, the consensus concluded that it can be considered in early stages, however, and it's not a contraindication for the use of PRP. Now, are there specific contraindications for the use of PRP in knee OA? Apart from the generalized contraindications for knee injections, like local infection and bleeding diathesis, those that are specific for PRP are malignancy, because platelet extracellular vesicles are known for micrometastasis. Then systemic infection. In this, platelets become hyperimmune, and there is no M1 to M2 macrophage transition that we would want from a PRP. Then qualitative and quantitative platelet disorders. Coming to antiplatelet drugs, this is a relative contraindication. Here there are two schools of thought. One says that we should avoid it, and the other says that simply use a higher draw volume so that you can make up for this. In what age is PRP recommended? There's no such age. Could PRP be used in inflammatory phase when joint effusion is present after joint aspiration? So the consensus does support the use of PRP after joint aspiration in patients with knee effusion. The level of evidence is limited. So let us look at this in depth. So a Japanese study found that in patients with knee effusion, as characterized in MRI by the worm scoring, these patients were given PRP after aspiration of effusion. Good WOMAC score, good VAS scale. Do recommend 3 intra-articular LP-PRP injections after aspiration of knee effusion. Then is a repeated cycle of PRP injections recommended after following previous successful PRP treatment on re-emergence of symptoms? For this, the consensus agrees to administration. So in a 2-year follow-up study, they saw that triple PRP injection gives a good result. Then another one compared single versus triple injection, and they found that at 48 weeks follow-up, in patients with mild knee OA, 3 injections is better than single injection. Then is there any rationale for injecting PRP in asymptomatic knee OA? Preventive use is not supported yet, though PRP is found chondroprotective in preclinical studies. Are there advantages of PRP use compared to corticosteroids in treating knee OA? PRP is safer, non-chondrogenic, and a long-term alternative to corticosteroids. In this landmark paper, intra-articular PRP versus corticosteroid was seen, and this is a systematic review and meta-analysis, and they found that giving 3 intra-articular PRP is definitely better than 1, and they found that intra-articular PRP produces superior outcomes as compared to corticosteroid in both pain management, reducing joint stiffness, and better exercise activity at 12 months. Also, this was a very good paper, though preclinical. In this, osteoarthritis was induced by steroids in rats. Now they administered PRP, and they got this result which says PRP protects mesenchymal stem cells from the toxicity of corticosteroids. Is PRP a clinically better injection option than hyaluronic acid for the treatment of knee OA? Consensus definitely supports PRP over knee OA. Since we're using it, let us see it in depth. In impact of PRP versus hyaluronic acid and synovial fluid blood biomarkers showed that inflammatory cytokines were reduced very well with PRP and not with hyaluronic acid. Then a combination of PRP and hyaluronic acid, they found that combination or PRP alone or hyaluronic acid had the same difference, and it was not better. An intra-articular injection of PRP compared to hyaluronic acid or saline placebo, this also found that PRP was better. Now coming to disease-modifying agents and disease-modifying effects of PRP in knee OA, and current clinical evidence is insufficient, though preclinical trials show very good effect. Then coming to autologous conditioned serum, they don't recommend it yet. And so also alpha-2 macroglobulin, it is also not recommended yet. Coming to preparation and characterization of PRP, now which is better, leukocyte-rich or leukocyte-poor? The consensus group doesn't support one type over the other. Both are beneficial, and the mechanism of PRP is multifactorial, and it is not only based on leukocyte. Now, the effect of leukocyte concentration on PRP, a meta-analysis showed that both leukocyte-rich and poor had good outcomes. However, statistically, leukocyte-poor PRP performed better than leukocyte-rich PRP, but it did not reach minimal clinical improvement. Then leukocyte-rich PRP also did not upregulate any inflammatory cytokines in knee OA. Then this double-blind RCT, this is an interesting study in which, of course, the clinical outcomes were better in both leukocyte-rich and poor. However, they saw that mild adverse events like knee pain and swelling were reported a little more in leukocyte-rich PRP, that is 12%, versus only 4% in leukocyte poor, but this was not statistically significant in their study. What is the recommended platelet number or concentration range for PRP injections in knee OA? This is a very important ongoing topic. And for this, the consensus is that optimal platelet number or concentration cannot be defined yet. And the mechanism of PRP is multifactorial. Growth factors and cytokine levels have no relationship with platelet numbers. And right at the time of this, clinical response versus platelet numbers was not yet established. After this was this consensus, in recent studies, there's one landmark paper by Angelo Boffa in which he saw the influence of platelet concentration on PRPs in knee OA, and he found that higher platelet concentration has lower failure rate and better clinical improvement up to 12 months. Another one by Bansal et al. Was multicentric with centers in India as well. They showed that a critical correct dose for clinical efficiency of platelets for chondroprotective effect in moderate knee OA is 10 billion, and they made it in 8 ml of PRP. This is another very important study by Gusti et al. This shows that there's a ceiling effect of platelets for promoting angiogenesis. In this, they found the magic number of 1.5 million platelets per microliter. Below this level, the number is not enough to promote angiogenesis. And after this level, the milieu is such that it inhibits angiogenesis. So in order to get 1.5 into 10 to the power 6, that is 1.5 million platelets per microliter, if we project it for 5 ml of PRP, we should be getting 7.5 billion platelets in our PRP for it to work for angiogenesis and healing. Then there are many RCTs. This one by Sandeep et al. This is also from India, and this showed that an 8 ml injection with 5 billion platelets was better than conventional. Then there are many systematic reviews and RCTs for showing the same. PRP preparations and products for knee OA, what should we measure in PRP for quality control? The consensus says that the composition of whole blood before preparing PRP and the composition of PRP should be measured. However, going beyond this, we have 3 classifications at least of PRP, in which DEPA classification also accounts for the platelet dose, the pause system, and the MARSPIN. Now, what is the recommended volume of PRP to be given into the knee? For this, they are not able to recommend any volume, and literature is found right from 2 ml to 12 ml. Here, Sandeep et al. From India have showed that 8 ml injection of PRP is better than 4 ml for a knee joint. Now, how many injections of PRP are recommended for knee OA? The consensus group recommends 2 to 4 injections, and the interval between these injections is recommended as 1 to 3 weeks. Why? Because the platelet PRP once given, the dense granules keep releasing the growth factors for up to 3 weeks. Then does needle size or syringe size matter for harvesting or injecting PRP? No, they don't matter, and the platelet integrity is not affected. However, if we use larger syringes for any aspiration, speed should be slow to prevent intravascular hemolysis. A study on this also showed the same thing, that needle caliber used for PRP injection does not affect platelet functionality. Now, coming to NSAIDs, are they allowed around PRP use? The consensus is NSAID should be stopped for 2 weeks prior to administration and for 1 week post-injection, and we should use paracetamol and tramadol for post-injection pain. However, this newer study was a review on PRP use in platelets taking in patients taking NSAIDs, and this showed that such a huge gap is not necessary. So for diclofenac routine dose, they said that you can defer for 6 to 12 hours only. For Brufen, it's 8 hours. Naproxen, it's 1 to 2 days. Indomet, it's 24 hours. And for acetaminophen, paracetamol, up to 2 grams per day, it is not necessary. There's another systematic review which says that aspirin, paracetamol, and non-selective NSAIDs should be stopped. However, COX-2 selective NSAIDs and statins need not be stopped. So paracetamol is a kind of controversy. Should intra-articular local anesthetics be given when injecting PRP? We don't give LA right up to the capsule. We can give up to the capsule. We don't penetrate the capsule with LA. Now, coming to local anesthetics on platelet physiology and function, the take-home message is that lignocaine up to 1% or ropivacaine up to 0.5% can be used along with PRP to reduce the pain while maintaining the therapeutic potential of PRP. Also, when it is seen that local anesthetics as such have cytotoxicity, and on top of that, if PRP is given, the cytotoxicity of these local anesthetics is reduced. Is antibiotic administration recommended around PRP? This consensus does not recommend the use of antibiotics around PRP use. After this, a few studies were done. A scoping review showed the antimicrobial effects of PRP and PRF itself. They are themselves bactericidal in nature. So we may not need to give antibiotics. Secondly, in the world of surgery, a study was done which showed that platelet-rich plasma along with beta-lactams mitigate MRSA infected skin wounds. Is fasting recommended before PRP use? No, fasting is not recommended. However, high-fat foods affect platelet function, so we should avoid them 24 hours prior to PRP, and alcohol should be avoided 48 hours prior. Can a patient have corticosteroid injections prior to PRP to improve the results? The consensus says that since most people already have got a steroid shot, we have to keep a minimum interval of 6 weeks between corticosteroids and PRP. So does PRP and hyaluronic acid have a synergistic effect? Data is insufficient. Is there synergy between PRP and cell-based therapies for knee OA? So here the consensus does not suggest a combination of PRP and cell-based therapy. However, whenever we do adipose tissue SVF or MFAT, we have to add PRP to it to decrease the viscosity, and we are then only able to inject. So coming to a summary, in KL grade 1 to 3 OA, PRP effectiveness is very well supported by literature. In KL4, only if the patient is not ready or suitable for TKA, while informing the lower results to the patient. Then no specific age restriction for PRP, and PRP can be used even in an inflamed knee after the effusion is aspirated. PRP is clinically better than hyaluronic acid and corticosteroids, and no significant difference between leukocyte rich and poor. 2 to 4 injections per cycle of PRP provide better results with an interval of 1 to 3 weeks. So conclusion is that these statements and recommendations in this consensus are not absolute. They have to be considered case by case in combination with clinical evaluation. Limitations: while some of the evidence is high quality, some of the evidence is only a consensus of expert opinions, so it's low quality. And as we saw, research is evolving and new studies are being published, so some of the views are becoming outdated. This is one wonderful paper which we can go through for top 10 articles on PRP. Thank you.
Thank you, Dr. Sai. This was a very lengthy article, and also you did a lot of research in the background to make it more interesting. A very brilliant effort from your end. Thanks a lot. And ma'am, should we take questions now or after second presentation?
After second presentation. Let's do the question at the end. Let
Okay,
Dr. Randheer present.
Okay, ma'am. So our next presenter is Dr. Randheer. He is pursuing his FNB in pain medicine at Sir Gangaram Hospital under the leadership of Dr. Pradeep Jain sir, eminent faculty of our pain medicine of India. So his topic is assessment of MRI changes on articular cartilages after intra-articular injection of PRP in knee osteoarthritis, an interventional study. Dr. Randheer, you can start, please.
Can you see my slides?
Yes. You are audible. You are visible. Your slide is visible. You are also audible.
Yes. Thank you. Good evening, everyone. I'm Dr. Randheer Annaram, Fellow National Board in Pain Medicine at Sir Gangaram Hospital, New Delhi. So I'm here to present a research paper titled Assessment of MRI Changes on Articular Cartilages after Intra-articular Injection of Platelet-rich Plasma in Knee Osteoarthritis, an Interventional Study. This is a multicentric collaboration between RG
Dr. Randheer, you have paused your screen sharing. Can you, your screen is not visible. Yes, now it is.
Yes.
Yes.
So this work is a multicentric collaboration between RG Medical College and NRS Medical College. So osteoarthritis is a leading cause of disability, largely due to cartilage degeneration. While many treatments offer symptomatic relief, none of them show reversal of cartilage damage. So PRP is being investigated as a regenerative therapy. MRI provides an objective tool to assess the changes in cartilage non-invasively. So this study combines both subjective and objective assessments. The implied research question is, does intra-articular injection of platelet-rich plasma improve MRI documented cartilage thickness and clinical outcomes in patients with mild to moderate knee osteoarthritis? This is particularly relevant as most existing studies focus just on the subjective outcomes alone. So the PICO format structure in the clinical hypothesis is that the population of the study has 100 patients with KL grade of 1 to 3 knee osteoarthritis, aged 45 to 65 years of both sexes. The intervention that is received is 3 intra-articular PRP injections administered 6-week intervals apart under ultrasound guidance. So this is a single-arm interventional study, so there is no control. And the outcomes are measured as cartilage thickness on MRI, which is objective, and VAS and whose clinical, which is clinical or subjective. So prior literature, including systematic reviews and meta-analysis, confirm that PRP reduces pain as well as improves the functional outcome. But these studies have only focused on subjective outcomes like VAS, NRS, WOMAC, or Q scores. So these studies, there is objective structural outcomes like MRI-based cartilage assessment is lacking. A few small scale studies with MRI had inconclusive evidence. So the population was about 100 patients with radiologically confirmed KL grade of 1 to 3 knee OA, aged 45 to 65, in coming to pain OPD in tertiary care hospital in West Bengal between October 2023 to August 2024. So the study involved computer-based randomly selected OPD data. And there was no control group. There was absence of blinding as well. And there might be performance bias due to because the patients already knew that they were receiving the PRP. So the inclusion criteria was along with the pain, history of pain, the ACR criteria for the knee osteoarthritis has to be there, in which age had to be more than 50 years, the stiffness had to be less than 30 minutes, and there had to be crepitus plus osteophytes. So there had to be radiological evidence of the joint destruction based on Pellegrin-Lawrence criteria, which included grade 1, grade 2, and grade 3. So if we see the age, it was 45 years to 65 years, but the age according to the ACR criteria was more than 50 years. So the people included in this criteria in this study between 45 to 50 years were 5 patients, and all of which had to be about Kellgren-Lawrence criteria of grade 3. So the exclusion criteria had patients with contraindications for MRI like pacemakers, aneurysms, aneurysm clips, claustrophobia, non-MRI compatible metallic devices, patients with autoimmune diseases, collagen vascular diseases, cancer, immunodeficiency states, active infections, inflamed or traumatic lesions in the knee deformities such as genu valgum or verum more than 20 degrees, mothers who were pregnant or in lactation phase, platelet disorders, patients who had low platelet counts, less than 1,50,000 per microliter, or blood dysplasias. Patients who have also received viscosupplements, ozone, corticosteroids, or any knee injections in the past 3 months. Also, patients with knee or other surgeries in the past 6 months. Patients who are on anticoagulants or antiplatelet drugs in the past 10 days, and NSAIDs in the past 5 days, and systemic corticosteroids in the last 2 weeks were all excluded. So this actually fits this is actually more than the recommended guidelines by ESSKA, as discussed before. So as we can see, the enrollment was of 125 patients, in which 12 were not meeting the inclusion criteria and 5 declined to participate. Out of the 108 randomized and allocated to the intervention group, there's only one group. So that out of which 5 lost to follow up and 3 discontinued. So a total of 100 patients with 200 knees were analyzed in the study. So the intervention was to actually take 40 ml of autologous blood from the anticubital beam in 4 10 ml vacuum trainers, which contains 3.8% sodium citrate solution. So the initial spin was about 1500 RPM for 12 minutes, and a 10-minute resting period was given. So after the 10-minute resting period, the blood separated as the bottom layer of erythrocytes, the middle buffy coat, and the supernatant plasma. The supernatant plasma was removed, and a second spin of the plasma was done at 2300 RPM for 10 minutes. And a platelet pellet was separated from the platelet-free plasma. This platelet pellet was rediluted to produce the PRP of approximately 1 million platelets per microliter, which is actually equated to 1 billion per ml of platelets. All in all, 10 ml of PRP was derived, in which 10 billion platelets were present, and 5 ml was given in each of the knees. So the assumption is that with 3 times of basal platelet count is what they have given. So we can assume from that an average of 330,000 platelets per cubic millimeter of blood was there. So there was no classification provided as to what is a platelet PRP. So there was no PRLA classification and PAR classification that was given in the study. Also, a platelet activator was added at the activation of PRP was also mentioned, but which platelet activator as to when it was given is also not mentioned. So the PRP injections, 5 ml each inside OT in aseptic with the aseptic precautions under ultrasound guidance with a linear probe in short axis orientation was used to look out for a suprapatellar recess and from lateral side entry approach using a 22 gauge needle. A total of 5 ml of PRP was injected, and after the injection, the knee was mobilized. The patient was counseled for potential pain that may arise after the PRP and was advised to use ice pack for cold compression, and tablet paracetamol 500 mg was also given chlorine attack. So this is a timeline. So an MRI is taken just before the first PRP injection, and after the first PRP injection, after 6 weeks, the second PRP injection was given, and after 6 weeks, the third PRP injection, and after a month of the third PRP, a second MRI was taken. There was no baseline CBC that was reported, or baseline platelet count that was reported, no absolute platelet count that was reported in the study. So the cartilage, the measurements would be measurement of outcomes would be cartilage thickness measurement, which was done using a 1.5 Tesla MRI with T1 weighted images and PD weighted fat saturated images of 3 to 4 millimeter thickness were given. And these were actually 3D reconstructed in both the sagittal and coronal axis, so that a complete cartilage thickness could be measured in the medial and lateral patellofemoral region, medial and lateral femoral condyles, and medial and lateral tibial condyles as well. So a total of 6 areas is where the cartilage thickness was measured. And then the pain, the VAS scores were measured from 1 to 10 and reported by the patient. More than 5 is usually associated with worse symptoms, according to this study. The knee injury and the osteoarthritis outcome score has been used for looking out for disability. This is a validated tool, but seems complicated as it has five items, 5 distinct subgroups. So 9 items were there for pain, and 7 items were to assess symptoms. 17 items were used to assess the activities of daily life. 5 items were used to assess sports and recreation function, and 4 items were used to assess quality of life. 0 was given as no problems, and 4 for extreme problems. And the score that is given for each item, each subcategory was subtracted out of a score of 100, and a total score of 0 to 100 was given, with 0 being maximum disability and 100 being no disability at all. So the sample size was calculated using the formula, and a total of 125 subjects were seen. So the power level was 80, which is a minimal standard acceptable minimum. The tools for the pre and post analysis was a paired student t-test, which was statistically all of these things were suitable for the study. So as we see the demographic data, so there was no difference in the categorical age groups, and there was a female preponderance as seen. There is no difference between the KL grading between the groups. It was the patients were associated with more heavier BMI, so obviously is one of the causation, probable causation for osteoarthritis knee, and the other comorbidities did not hold weight in having a causality, although odds ratio was not given. So the MRI cartilage thickness of the results were present, and all of the categories post PRP, all of the areas showed statistically significant increase in the cartilage thickness in all the 6 compartments. So that while this is a graph that is showing the cartilage thickness, and maximum is seen in medial and lateral patellofemoral quadrants. So the Coos and VAS score, the Coos score actually had a statistical significant difference in pre and post PRP. So there was 4-point difference, and then the VAS also decreased by 1.6, almost 1.6 points. So even though the cruise decreased was clinically meaningful, the authors did not calculate the proper formal effective sizes. So the cruise subscales, which had 5 subdomains, were not reported individually, but a total cruise score was calculated and given. So this may actually mask the variation in which functional domains the patient benefited the most. So no reporting of adverse events or post injection complications were given. And MRI in MRI, even though whose score was used, which there was no structural features like synovitis, meniscal integrity, and subchondral bone changes that was reported. The better way was to use whole organ MRI score, which actually could have given a much better, robust situation of the knee instead of just focusing on osteoarthritis. So the results, all the results were clearly stated, and some were underreported, like I just discussed. The comparisons were statistically significant, and the supplementary data was actually looks supportive and accurate. The null hypothesis was rejected, and the method consistency was standardized, but lack of details that I mentioned before would actually improve the reproducibility of the study. The follow-up completeness was good, and outcome measure validity was also good because it was both subjective and objective. Statistical significant statistical test used was appropriate. The power analysis was adequate. This effect size was not mentioned. So these were the other studies that were given in the review of literature and discussion. So out of which most of the studies were from 2013 to latest of 2022. Out of which only one was an RCT and 2 was in meta-analysis, most of which compared either PRP of 2 injections between 4 weeks apart, or single PRP injection with the long-term follow-up, or comparison with HA or placebo, or NSAIDs or steroids. So there was all of which showed significant improvement in WOMAC and VAS or CUS, but there was no MRI documented cartilage thickening even after 1 year, or some cases actually showed only one of 5 MRI scans which showed any statistically significant cartilage change. So the authors actually accurately positioned the studies stating that very few studies provide evidence of improvement using subjective measurement with MRI. So this is consistent in the study in 2020, which showed that some MRI changes are present, but it was in a limited cohort. And Halpan et al. Also showed that minimal structural change was present despite maximum symptom relief. So the hypothesis was that objective improvement in knee cartilage will be shown by MRI. This is important because it seeks to validate PRP just beyond symptomatic relief, just not as a pain relief, but also as a regenerative role. So what does this study add? It is a first large-scale study with 100 patients and statistically significant increase in cartilage. So there is, to an extent, a reproducibility with this study that can be done. There is correlation of symptoms of like objective symptoms of MRI with the VAS and CUS as well. So the strengths of the study include objective measurement, large sample size, validated tools, statistical significance, and ethical rigor. The weaknesses include there was no control group. There was a short follow-up after just 1 month after the last injection, and overall 3 months after the first injection. The gap was 6 weeks instead of a bare minimum of 3 weeks between the 2 injections, and there were limited parameters in the POO score that was reported. Only cartilage thickness was measured, but other issues that may coexist with osteoarthritis, like synovitis and all, were not reported. So there was lack of blinding. There was multiple bias in reporting, and the clinical, even though clinically, statistically, it was significant. The mean cartilage thickness was from 1.7 mm to 1.9 mm in the medial femoral condyle, which is the most important part of the knee compartment, had questionable significance. So these implications would be to encourage evidence and long-term follow-up of further studies with PRP in proving objective structural improvement. So PRP is minimally invasive and low-risk intervention, not only in the context of reducing pain, it also reverses the cartilage degeneration, is proven by this particular study with the tentative support. Thank you. I thank ISSP Gurugram and Annaram for this opportunity.
Thank you, Dr. Randheer. It was a great effort from your end. Although it was a very small article and very preliminary information they could pass on to us, but still a good effort, and you could bind all the participants here for your presentations. Can we have questions, please, ma'am, now?
Yes, let's ask the question. We have Mangas Dr. Madhur Chadha. You may introduce him. Sir, can you turn on your video so we can?
Yeah.
Hello, sir.
Am I audible?
Yes, sir.
Perfect.
So we have some questions if you can take
Sure.
Can you see the questions in the chat box, or should I read it to you?
Yeah, if you can read it to me.
So the first question is, will combined PRP and hyaluronic give better results?
Not exactly, not significant, statistically significant. It does add to 0.1%. Low dose hyaluronic acid has a role for inflammatory synovitis, as well as patients when they come down for the first time. If you combine with PRP, it will add to it. It will add to the decrease in inflammatory response and the pain curve. But overall, there won't be any statistical changes if you want to see the results in long term. Plus, it all depends, plus the amount of PRP dosage which we are given, plus the grade and stage which you have injected the knees for osteoarthritis especially.
Right. There were some theoretical things that, hyaluronic acid would act as a scaffold and, it'll just
Yes,
I don't know how far that has gone.
Scaffolding, all those 3D printing modules plus all those scaffoldings work slightly differently. For that, PRP is not the way to go about it. You need a lot of lab technologies, you need a lot of mononuclear cells count, plus you need culture cells. Then they add to it. PRP combining with hyalase doesn't really add much benefit. For those things, you need slightly different modules, and those culture technologies definitely add up. Even those stemspetic guys, once they have done the stempetic cells, though autologous, but they are dried cells, adding hyalase will kill it. So the dose has to be adjusted and then injected. So definitely inflammatory, it does. It decreases the IL-6 count slightly to an extent once you combine it. And if you single shot, you can combine it with your PRP volume exactly. It will help. for the anti-inflammatory effects, not for binding or scaffolding. Doesn't really work much.
Okay. And when to start physical rehab?
Physical rehab, usually if you don't have any inflammatory response, 15 to 20 days is fair enough. You start with that for a few weeks to months. It helps. Depends upon the condition and duration again, which the patient is in. Again, plus all those studies, the Curve Medical College, they have mentioned they have taken up to 20-degree Varus, which is just crap. You can't go above 5 to 10 degrees if you're doing regenerative medicine. So that study is kind of very lot of potholes. So be careful. Don't base your decisions on that studies. Avoid that.
No, I mean, this study has answered a lot of questions, in our day-to-day life, the first presentation. And I'm glad we
Yeah.
have some objective measurement with the help of second case
Yep.
presentation. Third question, sir, how are the results in meniscal tear or focal cartilage loss causing pain on the weight bearing?
See, again, depends which kind of grade 2 to grade 3. If you're able to inject it at the right site, plus rehab protocols are followed. In the end, over a year or so time, we'll get some scarring. The patients will have good pain control, the mobility will come back. But again, you need to read your MRIs properly. You have to understand what MRI you're reading, associate with the clinical findings. And if there's too much flipping, Bankart lesions, avoid. Simple, straightforward tears, you can definitely do it. Posterior horn tears are quite common, but they become slightly tougher to inject properly. So be very specific when you put your needles in where you're injecting.
I
And
think
again,
answer to
repeat.
that meniscal tear and focal cartilage loss, yes, we can do PRP in
Yep,
that.
yep, we can.
And they are asking how to proceed with PRP in case of, I think, new infusion. This has been already answered in the paper that you can aspirate and you
Yeah.
can,
See,
but they're
aspiration
asking.
in India. Yeah,
Mhm.
yeah. Again, in India, if you aspirate, be very careful that it is not a TB joint. You'll have end up when you start doing volumes, every 10th or 11th joint will be a TB joint, and you inject PRP in that. If it goes into a flare up, plus if it's a diabetic and a TB with a flare up, you had it.
Mm.
You'll land up in an orthotomy. We keep on having that. It's not so uncommon with us. So
Oh,
be
okay.
very careful. Okay, be very careful. When you see a lot of effusions, aspirate it. Give it time, don't inject immediately. Avoid. Plus, antibiotics are a must. You land in big trouble, court of law, if you don't provide antibiotics in India, no matter what papers say across world.
So how much
India,
time do
antibiotics.
you take, sir, between aspiration and injecting the PRP?
See, it all depends. If I have a very effused joint, I'll just aspirate, send it for culture, start on antibiotics, call the person after a month or so, and then only inject. Though PRPs have a very good antiseptic profile, they have a profile where the synovitis can come down, but you don't know what kind of synovial thickening the patient has. Is it a diabetic? Is it just some chronic infections they had previously? How many shots of steroids they have taken? What kind of microbe is lying inside latent? All these leukocyte rich or poor will activate it, and the flare-ups will happen bad, and nobody is going to protect you once that happens. In an institute you might get protected. In private practice, everyone is going to blame you, and you had it at that point. Okay, so be very careful with synovitis. In the end, you will also end up injecting synovitis if you're doing repeated PRP. So again, be careful. Always tell the patient this may happen. The chances are 1 to 2%, but 1 to 2% in a higher volume centers are big.
And PRP in AV and hip,
PRP, AV, and hip,
I think
early
stage one
stage,
and two we
1
can
and
do.
2, again, see, all depends. If you're able to decompress the core and then inject properly, it works. The PRP 1 and 2, even if you go with good rehabilitation, good proper protocols, SWTs, that is low grade shockwave therapies, they'll give you the equal results with PRP, nothing big. For AVN, because it becomes a larger joint, again, all depends upon the type of dosage, the amount of dosage, the platelet recovery rates which you obtain, 80 to 90%. So it all becomes lab technology, not possible in your daily circulation. So just one anecdotal, you did 2 cases and you got good results. It could be multiple things. Once you start doing volumes, you'll notice that PRPs are not very effective in AVNs to that extent. You need heavier cell count, you need something else. You need more better cellular therapies.
And sir, they said that in consensus, it was said that steroid and PRP interval should be 6 weeks for
4 to 6 weeks. Four
intra-articular
to four
injection.
to 6 weeks. 4 to 6 weeks is fair enough.
Four
If
to
it's a
six weeks is, but in
low
because
dose
in the
20,
objective study they did excluded only 3 weeks of previous steroid
Yeah,
injection.
at least 4 to 6 weeks. 3 weeks
4 to
is
6
slightly
weeks.
shorter because you'll have that. See, any steroid injections, if you do it, it will decrease the cartilage volume by the volume loss happens by at least 5 to 10% minimum. So for the cartilage to naturally, because it end plate end plate diffusions happens, which leads to these cartilage proliferation. So the Kerr study, the only reason you could show from 1.7 to 1.9 was even after a month, there is some angiogenesis which does happen. Plus, the patient starts moving. Plus, there's something called as a placebo effect, which will always happen when you inject even an oil into the knee. The patient will have a positive feedback response, which will give that idea that something is happening. And when you get an MRI scan done, you might show these differences. You might get it, but usually differences don't happen so soon. Regenerative
Yeah.
therapy, once you do, it takes at least 3 months to give you some response.
Yes. Yeah.
And MRI will take at least 6 years, 6 months to a
That's what,
year before you
yeah,
start
we have
working.
said at least, wait for 6 months to get an
Yeah,
MRI scan.
at least.
Yes. And they're asking about volume of PRP in grade 4, if you choose to do PRP in grade 4.
Don't even think about it. Don't even do it. Don't even touch it. Grade
Yeah.
4, just a replacement.
Yeah, and
In
then
India.
there are deformities as well. Why would you?
A lot of deformities, lot of bad, poor muscle strength. Even grade 4 doesn't need a replacement. Grade 4 just needs exercise. Tell them to
Exercise.
walk with
Yes.
that. And above 70, don't even tell them to get a replacement done. That is all mythical burst. It doesn't work. You see patients falling apart. You see patients having bad stuff. Regenerative does work to an extent. Again, see, the population bias is so big in India. They want everything done in one go. Regenerative is
That's
multiple
the problem.
studies
That's the
which you
problem.
need to do.
Everything they want to get it done in one
That
go.
is the very
That's
problem.
especially
Regenerative
in
is,
the private practice.
yeah, no one thing happens in one go. It is multiple, plus it doesn't become cost effective. So be careful when you're doing regenerative interventions. Always.
So a role of PRP in osteonecrosis.
Again, osteonecrosis, see, if it's an osteonecrosis, you need a lot of angiogenesis to happen. You need a lot of edema to settle. Doesn't really help to an extent, but yeah, if it's a hamate osteonecrosis, do it. If it's a talus one, do it. You need to get into the bone and do it, inject it, then do it. But again, if you're injecting an osteonecrosis, the needle is not properly placed, you might end up having a linear fracture. You might end up damaging the bone more than helping it out. So, pyrosteum infiltrate, do the dye, do the arthrogram, you'll see how it covers up, and then slowly you can go the needle in and then inject some volume base. It is just like kyphoplasty. Injecting it slightly will increase the volume surface. It will help you with the angiogenesis phenomena and slight recovery. So again, choose it. But if it's totally osteonecrotic and totally damaged, don't touch it. You might break the
Everything
bone.
goes by study, by case. That you have to,
Okay.
like, you can't just choose a diagnosis and
Yeah,
define it. That has to be. I think
always.
grade 4 we have already answered. They're asking meniscal tear. Do we need to inject into the tear or perimeniscal? Does it really make a difference? I don't think so.
See, what makes a difference is choosing the right candidate for a meniscus tear. Again, perimeniscus, if you can get into the meniscus, good. It's meniscus. See, once you go anterior to posterior horn meniscus tears are quite common. Medial meniscus, it is slightly thickened up. It's a linear tear. It's a bucket handle tear. Uh, Putting the needle rightly at the right point is seriously tough. Okay. So even if you get into the fibers, you do the arthrogram, you inject, it will help. But the problem is the dosage plus how the patients are going to respond and what exactly they are looking for. So if it's an active sports person, they'll respond much better. If it's a degenerated knee, you don't need to, you even if you inject in the meniscus, it's going to flow off because PRPs are very fluidic, very, what should I say? It's very liquidy and they won't stay no matter what you do. So you need slightly better concentrates, more bone marrows, more microfracts to at least put them into that linear dimension and make them coagulate. That's the stuff. So even if you do a fibrin plugs to an extent sometimes have a role, but again, as I told, younger population, meniscus tear, good idea to have it. Degenerative meniscus, it doesn't. There's a very important study. Degenerative meniscus really don't help out if you inject PRPs or even for the sake bone marrows and all that. So 20s to 35s, 45s, yes, you can do a meniscus tear to an extent, but as the age increases, the results are going to go
Yeah,
down.
degenerated meniscus is not. So the combinations people are asking, PRP versus growth factor concentrate GFC. What's your personal?
That's what I told you. PRP, growth factor, exosomes, leads, put microfats in, put your oil, put your coconut oil, everything has a role. If starting, the first thing which you learn in pain medicine was your biopsychosocial phenomena. Choose the patient correctly, then everything will start working. But once you start with regenerative, again, understand it's not just the platelet count, but the timing, the time frame when you injected, the amount you injected, plus the assessment you did, and then follow up, and how you deal with the client is where you start showing results. So if you do 10 clients, not even every individual is different, and the dosage has to be tailor made. So if you are just relying on your kits, you are going to fail, and you're not going to get the desired results. And always check whichever kits you're using, just check the platelet count, do a CBC, tell your lab ones to get the platelet dosage done, because you'll find that half of them are selling useless products.
Mm. And
So
PRP with ozone, I don't think that will be a
don't touch,
good
don't touch.
idea.
Ozone PRP never. See, you again, PRP has angiogenesis. Ozone will shrink the cartilage. It has a role. If you are just doing pure ozone, it has a role in a way if it is painful. And if you shrink something, if you decrease the enzyme concentration, if you decrease the chemical mediation, it will help. But then why are you using PRP? The combination doesn't make sense. Choose any one of them.
Sir, I think above 70, grade 3, grade 4. I think it's the same thing, same questions and repetitive. Um, Ashu, sir, do you have anything to add in any of the questions we have? Ashu Jain, sir?
Anji, Anji. Hi, Madhur.
Hi, sir. How are you?
So the most important thing is to, choose your patient wisely.
Right.
Explain what you are trying to do, and the biggest thing that has, created controversies to with our colleagues in Hyderabad, what we are, telling our patient about the results. So that has to be carefully done. And absolutely in grade 4, I don't think when the compartment has actually gone, nothing works. So it is up to grade 3. And quality of platelet is very important. So that is another big issue, that your processing of the platelet has to be very carefully done. So, and definitely with the ultrasound guided or something. So that is, I think, message to all our person who are doing, choosing your patient carefully, explaining them the best of the sitting. I think Madhur will agree, results are not more than 60-70%. And
Even TKI don't have results above 70%. So regenerative is a good procedure, but the problem is when you oversell it.
yes,
Surgeons
मैं
can
बता दूंगा,
oversell it.
all
एक simple
claims
point है.
are difficult, and absolutely I fully agree. No point to inject in a wet joint. So you just manage the joint first, and then add any platelet after the your effusion is being taken care of. So absolutely no point in doing that. So that will be my message, that you should wisely choose your therapies and your patients. Everything rest is okay. And then patient rehabilitation is most important. Just putting platelet is not going to help unless until they improve their posture and they don't do cordyceps strengthening, nothing is going to work. So that is
See,
my message.
5 years down the line, what regenerative medicine you are practicing will totally go away. There will be something totally different. So don't get attached to this is the best. No, this is not the best. This is just an average treatment.
Hmm.
Similarly, PKR, they are able to sell it because once the implant is done, the onus goes towards the patient. Your
Hmm.
job is done. When you put a platelet in or any cells in, the onus is 50% yours, 50% patient. The patient can jump on you, where you can't prove by any ways for at least 1 year that MRI has shown changes. So try to understand. So be careful. And pain medicine, already you're doing cool RF, lot of stuff. If you wanted, you can combine with that. Do it individually. If you want to inject a steroid, do that. Just don't jump that this is the best. No, regenerative is not the best. The best is how you assess the patient, as Dr. Ashu said. choosing it wisely and correctly, and then going ahead, because it is a potent bump. Regenerative science, try to understand. One wrong cell at a wrong place, the total knee flare ups, and then you had it. It is a very bad scenario once the knee joints flare ups. They are not going to leave you. Indian population specifically.
We had Dr. Pradeep Jain with us. Does anyone see him? Is he still here? Or probably he has left. Okay.